Good morning. I am Sramila Aithal. I'm a breast oncologist working at Cancer Treatment Centers of America in Philadelphia. I primarily see breast cancer patients of all stages. Dose escalation from control study. First off, it's been very clear from many subset analyses of ExteNET trial that duration of neratinib impacted invasive disease-free survival. So it also showed that people who stopped treatment earlier on within 3 months, there was no difference in their invasive disease-free survival as compared to those that took it for 11 months or more. So it's clear that in order to improve efficacy of neratinib, patients should complete their treatment and have to be compliant. So diarrhea being one of the most notable toxicity or side effect of neratinib, which happened in more than 90% of patients of all grades and almost 40% of grade 3 diarrhea in the trial. And that led to almost a staggering 16% discontinuation rates as a result of diarrhea. So this control study looked at the incidence and severity of diarrhea in patients who early stage hormone receptor positive, HER2 positive breast cancer, where they used dose escalation of neratinib as well as prophylaxis for diarrhea, which showed a significant benefit in improving its toxicity. So I definitely apply this in my practice. I begin with either 120 milligrams or 160 milligrams of neratinib and escalate to 240 milligrams daily thereafter. I use loperamide as based on the study that was used in a control study in cohort 1, or sometimes I combine loperamide with budesonide or cholesterol to help control diarrhea. With this strategy, clinically, I have seen less diarrhea in my patients that led to less dose interruption and almost no discontinuation. I've seen very minimal cases of diarrhea using this methodology. And also, as noted in the clinical study, so also in real world practice, I see that the diarrhea is more pronounced in the first month. Severe diarrhea happens just for about 3 to 4 days or so. And the strategy of using loperamide and dose escalation has been very useful in allowing patients to continue on with treatment. It works well. And besides, we have an excellent oral adherence program where we use a lot of decision aids or tools to simplify, to educate and tailor to the patient's level of understanding. We give them handouts. We have follow-up phone calls made by our nurses to evaluate adherence and so on, and that has gone a long way. Well, data from many clinical trials indicated that a substantial portion of HER2 positive early stage breast cancer develop recurrence even with recent advances in their treatment. We have seen in the data from BCIRG and joint analysis of NSABP31 and NCCTG study that there is almost a 25% risk of relapse. Even in HERA trial, almost a 30% risk of relapse. Catherine trial showed, even though it was major improvement over other over trastuzumab-based therapy, there was still a 12% or more relapse. So all of this is taken into consideration when we consider using neratinib, a small molecule TKI, to be used in this setting. And we know the predictors of recurrences from these trials, lymph node involvement, larger size of tumor, and also the response to neoadjuvant chemotherapy play a huge role in the risk of recurrences or relapse. I feel this is where neratinib plays a role in meeting the unmet need. So in this setting, neratinib, when given as a maintenance treatment following trastuzumab-based treatment, significantly improved invasive disease-free survival at 5%, more than 5.1% at 5 years. I think we got many insights from so many subset analyses of the ExteNET trial. So I inform patients of this treatment option while they are on their adjuvant trastuzumab or TDM1, so that they understand the role of additional treatment as maintenance treatment for 1 year, and they're better prepared. So I recommend in my practice neratinib to hormone receptor positive, HER2 positive early stage breast cancer patients soon after completion of 1 year of trastuzumab-based treatment, especially in high-risk cases like if they had residual disease following neoadjuvant chemotherapy or large tumor burden, large lymph node involvement, and so on. PCR, or pathological complete response, is one of the strongest predictor of outcome, and it has been well established that those who achieve a pathological complete response experience a significant improved outcome. So people who had neoadjuvant chemotherapy followed by surgery and still had residual disease are being placed on TDM1 based on Catherine data. So comparing TDM1 to standard trastuzumab in patients who didn't achieve a PCR. So nevertheless, there was still a 11% improvement, increasing 5-year invasive disease-free survival to 88%. So that means there is a concern for 12% or more of patients experiencing some sort of relapse or recurrence. So in this setting, it is encouraging to note that the results of external trial, where they looked into a exploratory analysis, evaluated more than 350 patients, of whom 295 patients who had neoadjuvant chemotherapy were left with residual disease. So in this setting, where they were given neratinib as an extended maintenance treatment for 1 year, it showed a 7.4% improvement in invasive disease-free survival at 5 years and a 9.1% benefit in 8-year overall survival. So I think this is a great option for such patients, and I strongly consider extended neratinib for my patients, especially those that did not achieve a complete pathological response to neoadjuvant chemotherapy and trastuzumab-based chemotherapy, or even after TDM1 in this setting of breast cancer. I want to say that treatment for early stage HER2 positive breast cancer is a long haul. Talking to patients earlier on about an extended treatment with maintenance neratinib, and to talk about it on more than one occasion during their treatment, will get them prepared for an additional year of maintenance neratinib. I think this way works better than informing them about using neratinib after completion of trastuzumab-based treatment. In my practice, I use neratinib in high-risk patients in hormone receptor positive, HER2 positive early stage breast cancer, whether they have received trastuzumab or TDM1 in the adjuvant setting, especially in those that did not achieve a complete pathological response, or where in tumors, in patient, the tumor burden was high or had lymph node involvement, and occasionally even in estrogen receptor negative patients who didn't respond well to neoadjuvant chemotherapy. So deciding on who needs it, who needs maintenance neratinib, is the most important criteria.